All right, so perfect segue. All right, so we got BUN going up over here in renal, right? We got a buildup of urea, which is a waste product, and then we have a buildup of like ammonia, right, in a liver patient, and that causes the patient to get more and more sleepy, more and more obtunded and stuporous, or a RAS that's -1, -2, -3, -4, -5, until they may need to be intubated, right? It doesn't really cause agitation so much. It causes a hypoactive delirium or a altered mental status, an AMS or ALOC, an alteration in level of consciousness. So ALOC, hopefully it's just temporary. Hopefully we're just going to fix the ammonia. We're going to, with some what medications? Lactulose and rifaximin can lower the ammonia. And then we have, like, the BUN is super high. How do we fix that? Dialysis. There's no medication for BUN, right? The only way to get BUN down is dialysis, right? So hopefully it's temporary, and we figured it out. They're altered because of this. But then they have BUN elevation and they have like a pneumonia. Well, I don't know which one it is. It could be either one. We're going to make sure we're on the antibiotics for the pneumonia. We're going to make sure we support their hypoxia if they're hypoxic, or if they're hypercapnic, we fix their CO2, because O2 and CO2 can cause delirium as well, right? O2 starts getting lower and lower and lower. They get a hyperactive delirium. They start getting really, really agitated and restless. All it says, like, why are the patient so restless, right? And you say, I don't even got a sat on the monitor. And you can get a blood gas and you see the PO2 is 52. All right, well, that's why they're restless. Let's provide oxygen, right? They maybe we're just that crazy patient in the corner, but they're actually hypoxic. They aspirated, let's say, right? So we have to identify that. That's the whole point of the CAM ICU. Like, they're really crazy today, right? They were +1 yesterday, now they're +3 today, right? Now they're +4. They're like hitting me. I got a security sitter. That's an escalation. That's an acute change in the last 24 hours. The RAS score has gone up, and they're not going to play the Casablanca game with you at all, right? So they failed all the strikes right there. Okay, so clinical exam is going to clue you in. Is it something focal or generalized? So generalized means there's a depression all the way through the body, right? There's not a movement at all, or there's not, or they are on the opposite side. They're restless everywhere, right? The reason why we bring up focal is because then we're getting to strokes. When we start seeing like they can't talk for some reason. You don't not talk when your BUN goes up. You don't just not talk when you're hypoxic. You don't not talk when your ammonia goes up, right? Yes, you don't talk because everything's shut down, right? But they still can talk when they're hypoxic, right? They help me. I need some oxygen, right? They have breathlessness, right? So is it something focal? They can't talk. Now we're thinking strokes, right? We're thinking a tumor. We're thinking an abscess developing on the stroke centers in the brain. So when you see someone's altered, you got to figure out, is it focal or generalized, right? So we'll talk about all kinds of focal stuff when we talk about like cranial nerves coming up and with strokes, right? Where they have a certain area of the brain is dysfunctioning, right? But here we're going to kind of focus on the general stuff, right? So focal symptoms, well, first of all, got to rule out something easy. If the blood sugar is low, right, that can mimic strokes, but also blood sugar is low has a unique feature of where it just causes a focal neurodeficit. You would think if the sugar is low, it's low everywhere in the brain. It is, but it actually mimics strokes. So low blood glucose can also cause a metabolic encephalopathy or cause a pathy of the encephalon being the brain, right? Causes a disease of the brain or disorder of the brain. It causes a change in mentation, and it's a focal change. So it's a focal lesion of some sort. And again, in the brain, we call if something's broken, we call it a lesion. We don't call it like a destruction or impaired function of. We say lesion. So you got a lesion of a certain area that glucose is more dependent on, and we should fix that, right? So if someone's altered, we should probably check your sugar first, right? If the AM labs at 5 a.m., you see the sugar is like 290, it's like, well, I know that when they get hyperglycemic, that can also cause confusion, right? Let's look at the acid status, acid-base status. Is the anion gap elevated? That could be a patient that might be going to DKA, for instance, right? And acidosis, that's a change in pH, and change in pH, can, either up or down, can cause a change in LOC, right? But going back to glucose causes focal deficits. Doesn't usually cause a broad depression unless it's like really, really low, like a sugar 20, then yes, they're not going to be awake at all for you, right? But as the sugar starts going down and down and down in the 60s, 50s range, you're going to start getting focal deficits. And then once you fix that and they still have the focal deficits, now we got to call a code stroke until proven otherwise. That means they have focal deficits. I can't move my right arm. I can't speak. I have slurred speech. I can't move my right leg. I have incontinence. Those are focal deficits, right? When I have too much CO2 buildup in a COPD patient, they don't just get incontinent. That's not a thing, right? They're going to start, yeah, they might get incontinent later, but if that's like the only thing that's wrong, that's a co-stroke until proven otherwise. And we'll talk more about strokes, right? And it's time for a CT scan stat to make sure that we aren't developing a stroke. Worst case scenario being the worst case strokes, which are your hemorrhagic strokes, right? And then now let's go back to global, right? So they got global or generalized ALOC. It's usually called metabolic encephalopathy until we can find something specific that has a better name for it, right? Metabolic encephalopathy just means I don't know what it is, but they are confused, right? Whereas if I say it's due to low oxygen, I have another name for that. I call that anoxic encephalopathy. It's a low oxygen state. If they have a renal issue and they're not getting rid of BUN, I call that a uremic encephalopathy. That's just, you might hear those things thrown around, but it's not wrong to say it's a metabolic encephalopathy. That is a metabolic problem, right? So if something's generalized, we got to see it wasn't causing something focal. We got to see is there something organic that's causing the problems, right? Is there a huge mass on the brainstem, for instance, that's causing my reticular activating system to shut down, right? Or bilateral hemispheric damage, right? When I have hypoxia, it doesn't just hypoxia. It's not just hypoxia just to the medulla, or just hypoxia just to the left temporal lobe. That's not how hypoxia works. When I have hypoxia, it's generalized to the whole brain, right? And a CT can show that. It can show anoxic changes. It can show cerebral edema from the hypoxia. Trauma of some sort, right? So they have a huge bleed, could cause a huge change globally in their mentation. And yeah, there are some bleeds that will just be in one specific area, like a hemorrhagic bleed. That's, yeah, will cause focal deficits. But hopefully the CT found that before, right? There's where we can't, it's not something focal, it's something, everything is shutting down or everything, they're getting super agitated for some reason, right? So really, really bad strokes can cause global damage, like brainstem strokes, posterior circulation strokes. Hydrocephalus, right? It's building up fluid and more fluid into the brain. It's swelling and swelling and swelling, and then it's going to start causing all brain function to start decreasing, right? So we get valley fever out here, and valley fever can cause a really bad pneumonia, right? Cocci pneumonia, but it can also make its way up into the brain and impair drainage of the CSF in the brain and cause a hydrocephalus to occur. So that might be the reason why and we would see that on a CT scan. And as we mentioned, hypoxia is going to cause a global insult to the brain, not just one area of the brain, right? And what happens is you get edema afterwards, and we'll talk about that next time. We talk about cerebral edema and what the causes are. Low sugar does it, low O2 does it, low blood pressure does it, because low blood pressure is low sugar and low O2 delivery, right? So all those things we want to try to avoid when we recognize someone has an insult to the brain. All right, brainstem lesions, that could be a CVA, it could be a bleed, it could be a abscess, it could be a trauma, right? Lesion just means dysfunction of in neuro. And brainstem compression. So we might have a bleed or an edema or something in the upper brain, but now it's starting to compress downward on the brainstem. When you have a global CVA deficit, all right, deficit from your stroke that's global, that's much worse than if it were just one little area. Because one little area, my cortex, I can't move my right arm or left arm. Whereas if that is getting bigger and bigger and bigger and compressing the brainstem, now you came in and yesterday they couldn't move the left arm, and now they can't, they're like flaccid, right? Or they're barely breathing, right? That is a sign of a changed LOC for sure. Like yesterday they were awake and alert, but they were able to communicate, but now they're like -3. They just kind of open their eyes, right? They barely stay awake. That's a acute change in their mentation. Okay, so that's something structural. Something structural is going on. There's edema happening, there's a mass happening, there's blood buildup. Now we're thinking of something physiological, right? So there's something metabolic happening. We kind of been talking about that. There's something, they got hypoxia globally, like an ARDS patient is really, really hypoxic. They're hypercapnic. When you get CO2 buildup, it's nature's natural anesthetic. It's going to cause you to start getting hypoactive delirium and start getting decreased mentation over time. Okay, and then acidotic, right? Things can't function good in low pH or high pH situations, so including neurotransmitters and brain functions. So everything just starts shutting down, right? Dyselectrolytemias. So they got electrolytes that are that are bad. So they're going to have changes in their mentation. And you think of sodium as CNS electrolyte, right? Sodium is always CNS, right? K is always cardiac. But sodium is always our CNS dysfunction, right? It can cause confusion, usually when it's hyponatremic, especially when you're dehydrated. Not sure if you've ever been dehydrated and you're going to find any kind of water you want. You're going to be pretty restless after a while. Okay, and that could be a simple thing in our ICU patient. I can't figure out why they're delirious the last 3 days. You look at the sodium, like in the high 140s. That's why they're delirious. They're thirsty, right? And then hepatic, as we mentioned, that is technically metabolic encephalopathy, but we're building up ammonia because our liver can't convert it, right? Or it fails the process of protein protein waste buildup, right? So usually proteins are bound together into a urea molecule, and that liver can no longer do that process. So the process gets interrupted, and ammonia starts building up, right? And then on the flip side, we make the urea, right, from excess proteins, but now we can't get rid of it. It stays in the bloodstream, and that's called a uremic encephalopathy. Azotemia is just a fancy word of saying buildup of nitrogenous waste products. Well, that's BUN, right? Is there any other nitrogenous waste product? No. So why don't I say amino acid encephalopathy? Because they made the same thing. Okay, and then CBC can tell us if we have an infection brewing, right? Can see if they have an elevated white count. We can see if the neutrophils are elevated. That tells you have a bacterial infection that might be developing, right? And then failure of the reticular activating system. So our RAS, which keeps us awake, it's failing because someone gave what? Someone gave benzos or opiates. So we got a quick fix for that, right? When you give a benzo or opiate, it doesn't make you like lose function of your right leg or make you become incontinent all of a sudden. It would cause a global deficit and cause a deficit in your breathing. So if that happens, we can give reversal agents, right? Reversal agents being our naloxone or romazicon, right? That's an opiate. Which one are you giving? Narcan. Yeah, Narcan or naloxone, right? So those guys can be given to reverse it, and obviously we've got to look to see, is there something else that's causing it, right? So is there some sedative medication that might be reducing my wakefulness, right? Let's switch them over to maybe like Precedex, or do they need anything at all? And then drugs to reverse. So they were reversing the benzos or the opiates, for instance, right? What is TSH? Thyroid stimulating hormone. So TSH, T3, T4 levels, if you have too much thyroid or too little thyroid, it can cause hyperactive delirium and hypoactive delirium respectively, right? So we're looking for changes in our TSH, right? Temp, when you get super cold, you're gonna start getting agitated. You start getting hot, you're gonna get agitated as well until things start shutting down, okay? So we got all these different changes that we're looking for. These are all physiological changes, right? We talked about mag being elevated, calcium being elevated. All these things kind of suppress your normal nerve functions. They start getting more and more depressed LOC. Right, and then calcium phosphate can cause some issues, not as much as our sodium. Sodium's really causing a lot of changes. Okay, ETOH, right? They're not taking ETOH anymore, or they snuck in some ETOH. Snuck in some ETOH might get more depressed unless they're a happy drunk. But otherwise, you take away the ETOH, right? You took away that inhibition of the GABA receptors, so now the GABA receptors kind of like went away, right? So now there's no GABA receptors. Now I have all kinds of withdrawal symptoms. And then not metabolic, something that's not something we can measure on labs. That'd be something like someone who's postictal, right? They had a seizure. The reason why they're confused right now is because they had a seizure, right? And they had a concussion of some sort, right? They had a concussion and a trauma. They have an encephalitis, which can't really easily be seen. So it's just a swelling of the brain, but it's not going to be picked up on CT. An MRI would show that. So that's why an MRI would be next. And then there's like no CT MRI findings. That's usually where we get an EEG. And we can see what's going on. Is there like diffuse slowing, or is there EEG patterns that describe something that we can maybe reverse, or maybe it's irreversible, like an anoxia event. Okay, so all these little labs and tests should make sense. These are all the things you're getting from the history. Do you have a history of seizures? Do you have a history of dementia? That might kind of combine things, especially when someone's demented and has like an infection that can make it even more hyperactive delirium. And we look to see, do you have a history of stroke? Because when people have strokes, have strokes in the future. So we look for all these different things. Your history of renal failure, well, shoot, what's your BUN, right? So all the history can tell you, and then of course your labs can tell you what of these changes may be happening. Okay, and then finally, so we talked about hemodynamic changes. Your cardiac output just low, that's low flow to your brain, right? You have or low flow to an area of the brain, that's a stroke, right? ICP is high. ICP is getting higher and higher and higher, and we'll talk about ICP next time. But your ICP is building up. That's going to start compressing structures everywhere, including the brainstem, including the reticular activating system, and cause you have a depressed mentation. Okay, and then neoplasm can also increase ICH. Trauma we talked about, and then drug induced, right? So alcohol or overdosing on medications, overdosing on meth, for instance, cause methods like SNS stimulant. So it'd be just a lot of SNS activity, a lot of hyperactive delirium. Okay, so do we give naloxone? Do we give thiamine? Thiamine's a great go-to drug. Anybody's altered, thiamine's usually given because worst case scenario, they could be malnourished on thiamine, and that could just be the reason why they are having symptoms right now. All right, LP might be needed. All right, if we can't figure out from CT, MRI, especially if you think of something infectious, right? Or you're trying to rule out a neuromuscular disease, but usually that's not to present with delirium. But EEG can tell us if there's something electrical happening that we can't notice on exam. Okay, and giving antibiotics for sepsis, etc. Right? So that's the idea. There's something focal or there's something diffuse. And if it's something diffuse, it could be anything, right? So that's what makes this a little more tough because everything's involved here. You got to know about renal, you got to know about liver, you got to know about overdoses. You have to put all toxins people can ingest. All that things being added up here in neuro and how it affects the brain.